talk, I think I invite Dr. Shetty, dynamic surgeon from Prasad Netralaya Hospital, Udupi. He'll be talking about decentered intraocular lens and IOL tilt.
A very good afternoon to everyone, and I thank you, Dr. KP, for this opportunity, and AIOS for this opportunity too. So I'll start with my topic, and that's decentration in IOL tilt. So I'll start with giving you a brief introduction about what's about decentration in tilt. So let's go about it. So basically, we see around this is not usually only due to your complicated surgery, but even after a normal cataract surgeries also we can see some of this what can happen. Usually the percentage from 0.2 to 1.8% of surgeries patient we can see this. Basically there is no clearly a definition for decentration or an IOL tilt, but in terms like what you can say is if we are seeing that pupillary axis and the IOL axis, the distance between that is what is called as your decentration, and the degree between that is called as your IOL tilt. So what is the cause for your tilt? So one, again, like when you have a capsular fibrosis or your haptics, you're not positioned it properly, your scleral IOLs, if you're not sutured correctly, your previous PPV surgery patients. So in all of this, patients, whatever is there, like basically when your IOL is not in position, some of any of these factors can cause your IOL to move from its place. That is what is going to cause you a tilt. So seeing for your decentration, mainly during your surgery, if you're having a large rhexis where your IOL is going to keep popping out from your rhexis, you're having a zonular weakness in one of your quadrant, again you're going to see your IOL being not in your position and it's going to keep tilting. Placement, again when you're trying to load your IOL, your one haptic is cut and you're still trying to go ahead with it. So that is where all these things happen with one haptic again in the bag or the sulcus. So this is during your surgery where a decentration is going to happen 100%. Next, where are you going to see again, like maybe days or weeks? One, again, like when your toric IOL gets decentered up or like during a patient with a zonular weakness. Months or later years, especially in trauma patients or pseudoexfoliation or Marfan's. So what basically happens in decentration? Why is it like, is it so important? If at all you have a decentration and that is more than your 1 millimeter, this is going to cause you your vision problems. It is all your aberrations are going to come into place. Your glare, your halos, your starburst, patient is basically not going to be happy. Vision is going to be decreased, astigmatism going to come and defocusing is going to be there. So once this starts, patient is not going to be happy at all and he'll start eating your head. What has gone wrong? And this is absolutely, even though he's got a premium surgery or a normal surgery, he's basically not happy. So what is the effects of decentration on your pupil? As long as the pupil is small, they might not feel it. But once the pupil starts dilating, all your aberrations are going to start. That is where they're going to start feeling it more. So how do we evaluate for the decentration? So let's start with like what is the degree of decentration, its complication, what it can get into, and what are the main symptoms what the patient comes up. Mild is when the optic is still there and there's a very mild decentration when it's like more than your half of your pupillary space is still covered by your optic. If it is like moderate, it's already like crossing your less than half of your pupillary space. Subluxated, it's already hanging down. Luxated, it's already down there. So what are the complications again when you're having a decentration? One, an inflammation, your IOP increases, retinal damage, CME, or vitreous incarcerations. Already these are some of the major complications which you're going to see in the patients with decentration. Symptoms, as I said, glare, floaters, monocular dysphosopsia, decreased visual acuity, and it all again depends upon your degree of malposition of your IOL there. So how are we going to measure this? Like, the exact degree of your decentration or tilt. Usually, like starting, we used to use this Purkinje meter. When you used to get that image, the third Purkinje image which you used to get, has to be full. In patients of this decentration, you're only going to get a half of your third image. So that is what in the Purkinje meter which you're going to get. And second, the patient needs to take for a long time to sit and take the image, and you are not going to get the exact values. Coming next, like you upgraded to UBM. UBM, you can get the amount of degree of decentration, but you are again using a coupling or the eyeball can be deformed, so that is again going to alter your value. So you exactly cannot know the exact degree of decentration or IOL tilt by UBM. You can make out, definitely you can come to know whether there is a tilt or a decentration there. Next, coming to your seam flub imaging, this is going to be very fast. You can make out all your eye ocular structures in that. The only major drawback here is you need a pupil dilatation of more than 6 millimeter. So if at all your pupil doesn't dilate more than that, you are not going to get this. Next comes to the ASOCT. Before they used to construct a 3D model. In that, like they used to get to know what is the exact degree. But now, like in the newer module, like your Cassia and IOL Master 700 and all, they can exactly get from the software the degree of decentration and the tilt which is available there. Next, coming to eye trace, that's again a ray tracing aberrometer which is going to give you a topography and your wavefront aberrations which are there in this. So this has some, like when you're going to see the topography map in your eye trace, your higher order aberrations are seen. So that exactly you can make out which is more, your comma, your trefoil, what is more, what is causing your aberrations to occur. Even in eye trace, there is something called as like the dysfunctional lens index. You see the value. If the more the value is, it is good. If it comes the lesser, then you are seeing the image being distorted, so you know what is exactly causing it. So this is again like a small example where a patient was implanted with an iris claw. In the first diagram, like we can see like what are all the aberrations which is causing here, your astigmatism which is causing here, and this is what is your residual refractive power which is left. But the same patient, when you take it up and you reclaw it again and you make the lens stable, the whole thing is changed. Your astigmatism is changed, your refraction is changed, the amount of aberrations what has occurred is changed. So basically your the patient starts becoming happy. So how are we going to manage it? So the if it is like very small amount of decentration, patient is asymptomatic, you can just leave it and keep observing it. But the time patient is symptomatic, you can take it up anytime. You don't need to wait it out. If at all you're already like it's on the table, you're seeing the half of your haptic is cut, all those things. So it's no point like you leave it for a long time and then again it is going to be a mess to take it up. Depending upon the situation of how bad or what the complication is, that is the time like you go to intervene. So what are the main, again, like how are you going to intervene? One, either you try to reposition it, you try to remove it and exchange it, or then again like last you go with your secondary IOLs. Before you do anything of it, like when you see the decentration is already there, try to do like a proper anterior vitrectomy, take a VR opinion if at all you need, and you try to manage the subluxation. Outcomes and complications, finally you see like it all depends on your preoperative macular function, complication of your final operation, and your CME or RD which is occurring. Surgical approach is mainly limbal or pars plana for depending upon your decentration. So repositioning, correct the alignment of your toric, correct the black placement, sulcus placement if it's already your bag is gone. If at all you need to still go ahead with the black placement, put a capsular supporting device if it's possible. If you're exchanging it, use your sodium hyaluronate, use your IOL cutting forceps. If you're going ahead with the SF IOL, make sure it's a 4 quadrant and you tighten the suture, or if it's a 2, this thing, you make it like a 180 degree apart sclerotomy. So summary wise, management strategy is important. Decentration more than your 1 millimeter and your 5 degree apart is very important. Use your capsular support device wherever it is necessary. Hydrophobic IOLs are better because it's not going to cause you much of your capsular fibrosis. So negative impact of the patient has to be addressed. Visual performance, especially in your multifocal or torics, make sure your toricity is aligned, and that will again, will not give you your IOL tilt and decentration. Thank you for your time. Thank you.
Thank you, Dr. Shamanth, for